Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Naha Balada from Roots Community Health, reporting for the week of August 26, 2024. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID, we will provide some information about cough and respiratory issues and the pulse oximeter device. Taking a look first at wastewater nationwide, SARS-CoV-2 concentrations are still considered very high. If we look all the way over to the far right, that area shaded in gray is considered incomplete because of delays in reporting. So that area is subject to change, but still, we're finally seeing that 3 out of 4 areas are looking like they are starting to come down. So let's hope that continues to hold true for those 3 regions. As for the 4th region, that is the Northeast. That is the one that currently appears to be heading up, although it's not nearly as high as it was this past winter. So for whatever reason, the West already exceeded its wintertime peak. Hopefully now it's heading back down. The other areas did not quite reach their wintertime peak and seem to be heading back down. And of course, we should keep in mind that this is a very broad look, looking at the direction of things across the entire country and across these broad regions. But if you really want to know what's going on in your specific area, you'd have to look at local reporting from a sewer shed near you. Here in the Bay Area, where we are in Oakland, there's been a big drop of how many sites are reporting anymore, due apparently to funding for different programs ending. We're also hearing that locally there might be some new wastewater programs being implemented. So it does seem like things are still in motion. And this is probably going to be highly variable depending on where you are. So worth reaching out to your local public health departments if this is something of interest to you. Now taking a look at emergency department visits. This is the percentage of emergency department visits with diagnosed COVID in the United States. And each of those blue vertical lines represents the weekly percentage of emergency department visits with COVID. And the red line there is the 7-day moving average. So we can see, looking way over to the right, that lately the percentage of emergency department visits with diagnosed COVID appears to be leveling off. So hopefully we'll see that definitely coming down. We'll just continue to watch this and just keep in mind this is for all ages combined. So one thing that I wanted to review today is that it does look different depending on which age group you're looking at. So this is the breakdown by age. And again, looking over to the far right, and you can kind of scan from top to bottom, and you can see the most affected groups by percentage of emergency department visits in order. So that yellow line at the top, then the purple line is next. So the highest percentage is actually in our 0 to 11-year-olds, so our babies and young children. The second highest is the 75 and up group, and that's followed by 65 to 74-year-olds. And then fourth is the 12 to 15-year-olds. And so you can probably see that a little bit more clearly here, that fourth one, the 12 to 15-year-olds, that is just headed pretty straight up there. And this is presumably could have something to do with going back to school in the last few weeks. But again, once again, the 12 to 15-year-old group is now the 4th highest group as it relates to the percentage of emergency department visits that are due to COVID. And remember that emergency department visits is really just a way for us to get a more timely sense of the burden of COVID. So I think what we can say here is that the highest burden by age group on the emergency departments is 0 to 11-year-olds, followed by the older age group 65 and up. And then that burden appears to be increasing in the 12 to 15-year-olds, which are the 4th highest age group here. And last, taking a look at deaths, the last week that we have complete data for is July 27th. So about a month old. There were 696 deaths that week, so almost 700. And concerningly, the next 2 weeks after that, which are preliminary still, that's why they're in gray, those are already each over 700 deaths. So we know that those numbers will only go up. So we're getting into the range of over 2,500 deaths per month now and climbing. So I really think it might be one thing if cases went up and down and the deaths stayed low, but we're not there yet. Cases go up, deaths go up, and even in the thick of so-called respiratory virus season, so the winter months, even then, COVID deaths far exceed flu and RSV put together. And we know that COVID deaths are not just in winter, not just in respiratory season. So that is year round where we do get a reprieve with flu and RSV. So here we are in the middle of summer, over 2,500 deaths per month from COVID. So this is not something I think we should just accept. We do need to do more to bring this down and at least in line with other causes of respiratory conditions, because right now it is eclipsing everything else put together, basically. So one positive update, piece of better news is that the 2 of the 3 vaccines that we expect for the 24-25 updated COVID vaccine have been approved by the FDA. So Pfizer and Moderna COVID vaccines were approved last week. They should be available any day now. We are hearing some places already have it, already scheduling appointments. We've been hearing first week of September, so we'll just keep you updated on that. But definitely you can be calling and checking around if you are ready to go ahead and get the vaccine. And the Novavax vaccine, that third one, has not yet been approved, so we will be keeping an eye out for that news. For most people, there's no reason to necessarily wait to get this. There have been a lot of very conflicting and sometimes odd headlines about this. I think at this point, perhaps people just have differing opinions, which in my mind is coming from the fact that this vaccine just does not cover you for a year. It does not cover for the multiple COVID surges that we are having every year. It's definitely not covering for both the winter and the summer surge. So if in fact what we really need is a twice yearly vaccine, then that recommendation should be forthcoming. Right now, that's only a recommendation if you have certain immunocompromise or if you're 65 and up. So if you fall in those categories, perhaps getting into the mind frame of twice yearly vaccine, at least until we have better vaccines, may be the way to go. We know that not that folks aren't necessarily doing that, but might be time for a little bit of a rethink. We see just how big this surge got in the summer, and perhaps that would have been avoided considerably if there was more of a twice yearly. This isn't my favorite idea, believe me, but I'm just in the reality of how these vaccines are currently working. Hopefully this will change. Hopefully the mutations will slow down. Hopefully this won't have to be like this forever. But right now, I do think that's a situation that we're in. So what some of the headlines seem to be kind of telegraphing is that since this isn't going to cover you all year, and since we might only be getting it once a year, then you may just want to time it for when you think you're going to be doing your most high risk activities. So you may be going on a trip next week. You may be planning to travel during the holidays. So what do you do? Well, we know holiday travel is a pretty high risk time, but let's say you have no intention of traveling over the winter holidays, but you travel in the summer. Well, maybe the way you time it may be more towards when you have high risk activities. So this is certainly not ideal, but I think we do need to be a little bit in reality about the fact that the way that the um, timing is seeming to want to be aligned with the flu vaccine isn't the way that COVID is aligning itself. So that is why you may be seeing some of these headlines out there about not rushing or waiting or things like that. So the other piece of it is we know how many people, or we know that a lot of people just had COVID. And so there's also consideration to waiting. Those guidelines also are not really hard and fast. Once again, if you're about to be exposed in a potentially higher risk situation, that might be different than if you're super careful and you wear a mask everywhere. You may think about your timing a little bit differently. But in general, we think that if you've had COVID recently, that you will have some protection for at least a couple few months. Of course, that means that you won't end up encountering a super different variant of COVID than the one that you just got. We know that you could get reinfected if it's different enough, but because some of the immune response that we mount can be broad enough to cover similar variants, we think you have a good 2 to 3 months of protection. And when you then get the vaccine, you'll probably get a little bit bigger immune response than if you get it very closely to the time that you had COVID. So it's definitely not a slam dunk. Unfortunately, we don't have any tests that we can just do to tell us, is it time for us to get another shot? That would be useful. Don't have that yet. So very imperfect situation that we're in, and we'll just continue to do the best that we can do. For most people, if you have not had a COVID vaccine this year, the new one is coming out, then you may want to consider going ahead and getting that once it's available. So the other thing is that, unfortunately, and I reported on this a couple times already, the Bridge Access Program is also ending this month, so it won't include the new 2024-25 vaccine. No more free vaccine. And so if you have insurance, you should be covered. This includes Medicaid, but we know that there's going to be folks who simply cannot access the vaccination. It's too expensive, or they don't have coverage. And this is one of the ways we know disparities will get worse. Those who are the most marginalized get more marginalized and get more exposed and sicker, and those with means get what they need. And so that is how disparities widen. This is something we have seen time and time again. And it is one of those things we're referring to when we talk about systemic inequities in healthcare. And I'll talk about one more important example in just a bit. So to recap, here we are in late August. Wastewater is showing that we have very high levels everywhere, maybe coming down in some areas, maybe going up in others. Emergency department visits might be leveling off. Deaths had hit a low point sometime in June, but have been heading up ever since and continue to do so. COVID remains a leading cause of death, and it is in fact the only single infectious agent that is a leading cause of death in the United States. And of course, death is not the only bad outcome. We have many post-COVID and long COVID impacts that are contributing significantly to prolonged sickness and disability. And we know that long COVID and post-COVID is just a variety of organ systems and issues that it can cause. We're learning more about this all the time. We'll be doing another update on long COVID in an upcoming briefing. But one consequence we know about can be a prolonged cough. And for some people, they are left with new or worsening respiratory disease. I went over some of this in a lot of detail in a March briefing. The link to that is in the post. This was a large population-based study that looked at a couple 100,000 patients in the UK. And the bottom line from this analysis was that after COVID, there does appear to be an increased risk of developing respiratory disease. The risk of developing a respiratory disease increases with the severity of the acute infection. The risk of developing a respiratory disease also increases with reinfection. And the risk of a couple of respiratory conditions, asthma and bronchiectasis. And bronchiectasis is when the airways kind of get bigger and they can sort of accumulate mucus and make it harder to kind of clear things out, make you more susceptible to infection. But these two things actually appear to continue to increase even during the 24-month follow-up period after COVID. So the authors of this big study suggest we need to put in place follow-up strategies for these folks so that we can monitor and manage the possible long-term respiratory health issues that come out of COVID. Once again, if you're interested in this study, I went into a lot more detail in the March briefing, but I do think it's going to take more time and more study before we can really quantify this well and be able to estimate what we can really expect to see as far as post-COVID respiratory issues. I think for some people, what we're really seeing is just a prolonged cough. for several weeks, and then it will just resolve altogether. And we can see this certainly with flu and RSV and other respiratory conditions where you just have a post-viral or a post-infectious prolonged cough, and then it can resolve altogether. For others, maybe they already had some mild disease and then the COVID just worsened that. And for others still, they really may get a newly acquired respiratory condition after COVID. But I will take this opportunity to say that cough is not something that we should just keep on living with. If you have a cough that has lasted for too long, even if it is after infection, then that is something that we likely would need to get worked up with a physician, just get an assessment, maybe get some evaluations done. And so generally, certainly if a cough is worsening, if it's waking you up at night, and if there's shortness of breath or other symptoms along with that. But even if it just feels like this lingering, annoying cough, definitely if it lasts for more than 8 weeks, this is something we absolutely need to get evaluated. There's a lot of things that can cause cough, even outside of an acute infection with COVID or flu or RSV or something like that. There's also, of course, smoking. Also allergies that can lead to postnasal nasal drip, which can cause cough. Reflux or heartburn, that can also give kind of a chronic annoying cough. Heart issues like congestive heart failure can cause cough. So really, there's a whole host of things that can cause cough. And that's why we just shouldn't take it lightly or make any guesses or assumptions as to what's going on. So I'm going to use this opportunity to briefly speak on asthma and COPD because those are two relatively common causes of recurring cough or chronic cough. They're also something that we are seeing increase in this COVID era, so post-COVID. And so I just want to do a quick recap overview of some key differences between the two. And one of the reasons why I'm doing this is because COPD in particular is really underdiagnosed in general. And maybe it's because it can come on over time and people just get used to having this cough. Also, there's still a big burden of asthma in our community, and asthma, even though we do a better job of diagnosing it, we don't always do the best job of controlling it or treating it. And so we still see a lot of issues with it. So just a brief recap here. So asthma usually presents itself in a younger age group. So it can be in kids, but basically usually under 20 years of age, whereas COPD is usually more likely over 40. The symptoms can look the same. And so that's why you see why sometimes some people might not know which they have. They might have been told they had either or both at some point. So, but it's important to get these differentiated because the treatment and how we approach it is different. The causes are different. So asthma is typically genetic and certainly can have environmental triggers, where COPD is usually caused by some kind of lung damage, most commonly from smoking, but could also be from other toxic exposures. And both of these conditions can be marked by exacerbations that happen for different reasons, different things that provoke an exacerbation. And with asthma, it can definitely vary significantly from person to person. So sometimes it is allergens like cats or dust. It can be cold air that can be triggering, or sometimes exertion or infection. And with COPD, most commonly, we see bad exacerbations that can happen after getting something that might be a simple respiratory infection in one person, but that lands someone with COPD in the hospital struggling to breathe. And in asthma, you'll have a normal x-ray and normal lung functions in between your symptoms, in between your exacerbations, things will be normal. Whereas with COPD, both the x-ray and the lung function between symptoms will have some abnormalities. So once again, cough is not something that we should just normalize or just say, oh yeah, I always have this little cough. This is something we want to get diagnosed and treated if that is what's indicated. Of course, we want to prevent particularly COPD. We want to also prevent exacerbations in asthma by removing those triggers. We want to quit the smoking, the exposures that may be causing the problem. But once you do have COPD or emphysema, getting the diagnosis and the treatment right can definitely improve your symptoms It can improve your quality of life. It can improve even the outcomes or the course of the disease. And this is, of course, true for a number of things. But once again, we want to make sure that people know, don't just accept a chronic cough. If you or someone you love has a chronic cough, let's not just accept or normalize it. Let's get it checked out and see if there's something we can do about it. So one thing that all these respiratory conditions have in common, whether it's acute COVID, whether it is asthma or COPD, whether it is congestive heart failure, is that one of our main concerns is not being able to get enough oxygen. And we know that this can cause permanent damage when there's not enough oxygen getting to the brain or to the tissues or other organs of the body. And how do we measure oxygen in the blood? Well, chances are you have seen one of these. It is called a pulse oximeter device. And it measures the level of oxygen in your blood, and it can warn you if your blood oxygen levels are too low, indicating that you may be in medical danger. It is an important device that can help save lives, and that is why they can be found everywhere, in every hospital, in every doctor's office, every clinic, and every ambulance in the country has pulse oximeter devices. You might even have one of them at home. You can buy them at most any pharmacy as well as online. But there is a problem. The pulse oximeter is not reliable when used on people with darker skin. In fact, the pulse oximeters routinely overestimate the blood oxygen level of people of color, which would make you think that they're healthier than they actually are. And this is a huge problem. It is quite likely that many people of color have died because of the erroneous pulse ox readings. It's a problem that we know has led to delayed or denied medical treatment for hundreds of thousands of people just during COVID. And that is not to mention the decades prior to COVID. And that's not to mention the going forward, which is why we are on a mission to make sure that this is not ignored for any longer. I don't know why for more than 20 years, the pulse ox industry and government regulators have failed to fix the problem, have failed to warn us about the problem. The pulse ox industry's mistakes and inactions probably would have gone unaddressed or unnoticed even longer if it was not for the COVID pandemic. So the travesty came to light, but even though it has come to light, still not much is being done. So we are not giving up. In fact, we are ramping up our efforts. And as part of that, we are trying our best to get the word out as much as possible. And one way that we're hoping to do that is through this 1.5-minute video, which you will be the first to see here on the briefing. It is linked in the post, and I hope that you will share it widely and you are the first to see it right here, right now.
Studies have found that pulse oximeters are inaccurate in people with darker skin. The study was widely covered in the media by the end of 2020, but went largely ignored by the leading manufacturers and sellers of pulse oximeters. The results may have been deadly. The primary way to diagnose hypoxia is a pulse oximeter, but pulse oximeter readings in people with darker skin consistently show that their blood is more oxygenated than it really is. Pulse oximeters jeopardize the well-being of patients with darker skin by concealing the medical risks they face, and thus masking the need for timely, life-saving treatment. It also contributes to the racial disparities in health outcomes we see today. The percentage of Latino, Black, and American Indian or Alaskan Native people who have died from COVID-19 is higher than their percentage of the U.S. population. Black patients are approximately 3 times as likely as white patients to obtain an inaccurate pulse oximeter reading. This can be the difference between rushing to the hospital and receiving medically necessary oxygen treatment or not. The documented limitations and inaccuracies in pulse oximeters have been known for decades, yet nothing has changed. That's why Roots is taking action. We filed a lawsuit against the leading manufacturers and sellers of pulse oximeters. The lawsuit demands that they fix the device, Add a warning label about its flaws or stop selling these devices altogether. For now, establish your baseline and talk to your doctor if you're not sure. Tell family and friends about this issue and bring it up to your healthcare providers. Don't assume they know. Stay tuned on the latest by following us at Roots Empowers.
Please share that widely. One of the things I want to emphasize from this is that the pulse ox flaws are not only a problem when it comes to COVID or flu or an asthma or COPD exacerbation or any respiratory issue, which might cause you to call an ambulance or to go to the hospital. And they will use the pulse oximeter device in those situations to decide if you may need oxygen or not, to decide if you may need to be admitted to the hospital or not, or to decide whether you need certain treatments or not. So this is obviously a huge, huge issue that the device just does not work equally well on people of all skin tones, which may mean that right when you are experiencing an acute illness, you don't get the correct assessment or the correct treatment. This is a major problem, and it's not the only problem. Another devastating issue is that the pulse oximeter devices are often used to qualify people for home oxygen. In fact, the doctor won't prescribe home oxygen and Medicare won't pay for home oxygen if you don't meet certain criteria, which is normally ascertained by the pulse ox device. And since we've been speaking out on this issue, many people have reached out concerned that their loved one is being denied home oxygen, even though they seem like they struggle to breathe and even though oxygen helps. And unfortunately, that is the situation, that your pulse ox reading is looking too high. And if you think that this is happening because of the pigmentation level in your skin or because of faulty pulse oximeter devices, you would need to be referred to a lab to have your blood drawn from your artery, which is usually done from your wrist, to get a more accurate assessment of your oxygenation in your blood and to get you qualified for home oxygen. So please do spread the word on that, because home oxygen actually can improve the quality of life as well as your prognosis or your likely course of your disease, particularly for different types of chronic diseases that may warrant the home oxygen prescription. So please, please be aware of that. We can be as outspoken as we want about these flawed devices and about yet another systemic inequity in healthcare, and we have every right to. We all deserve devices that work equally well for everyone. And it is important that we be part of the solution. So I'm going to review a few ways that you can do that. So until these pulse oximeter devices are fixed, we want anyone and everyone who's willing to listen, to know about this. So inform your medical provider. Every time you go to the doctor's office or to a hospital, every time a pulse oximeter is clipped to your finger, it is an opportunity for you to help educate the person taking the reading about the dangerous flaw in this technology. It is super important to raise awareness, and you will be surprised how many even medical professionals are still unaware of this issue. And consider spreading awareness beyond even health professionals. Share out the video. You never know who needs this information and where it could save a life. Also, if you work with different organizations or you are in different networks, consider sharing it that way as well. And support really any community initiatives that you see that address disparities in healthcare or health assessment and monitoring, because here is a very clear and obvious example of how systemic inequities in healthcare work and an opportunity to plug in. But sadly, there are many, many more examples where this will pop up. And once you start seeing it, you really can't unsee it. So hopefully you can be part of educating those who maybe still don't believe that there's systemic inequities or systemic racism in healthcare. And this is a great, unfortunately awful, but perfect example of what that means. And collaborate with your providers, with other folks in the scientific community, if that's what you work in, or in public health. And let's do what we can to reach everyone. What you can do for yourself personally is to establish your baseline. So this means, like, especially if you have a pulse oximeter device at home, or if you're thinking to get one, that you establish how you are when you feel healthy, when you're not sick, and that can be considered your baseline. And we'll be putting out more information that gives you some detailed instructions about how to establish your baseline, both at rest and when you're exerting yourself, because that can be helpful if you're not feeling well and you have a drop of, let's say, 3-4 points. That is significant, even if your number looks okay, which again, if you have melanin pigmentation in the skin, the number may falsely look okay. It may be falsely overestimating your oxygen. And another way that we can be part of the solution is to be part of the clinical trials and assessments that are out there. So again, we have every right to be concerned and frustrated about inadequate representation in clinical trials. And at the same time, we would have to be ready to conduct clinical trials. We will have to be ready to participate in clinical trials. So I'm calling your attention to the study going on at UCSF across the bay from where we are, looking at the performance of pulse oximeter devices in people of all skin tones and people with different underlying issues and conditions. And so this will be part of what's needed to learn more and to improve upon the technology that we have now. So there's a QR code and information. So please do consider it. Please do share with friends and colleagues who may be in the area. We all deserve tools that work for us, and we will likely need to continue to be part of the solution there. And speaking of tools, the federal government has announced that beginning in late September, we will be able to get 4 more free COVID-19 tests. Sounds like they can be used through the end of the year. So I guess we're getting some short dated tests. I don't know. Make sure you look at the expiration date. I'm sure a lot of us would have found this handy over this summer wave, but free is good. So make sure you get yours and keep an eye out for that. In late September, we'll certainly update once that link goes live. And in the meantime, let's do what we can to prevent the spread of respiratory illnesses and prevent getting SARS-CoV-2 in particular. So let's get the updated vaccination when it's best for you. Wear a high quality filtration mask indoors, gather outdoors whenever possible, and pay attention to your indoor air quality and do what you can to improve it. And then let us also make sure we are strategically testing, repeat testing, especially if you have symptoms, any kind of symptoms. You could think it was allergies, a stomach flu, or anything else, but it's pretty much COVID until proven otherwise. So isolate until you confirm. And if you don't have a primary care provider, please get one. Tell them all about the pulse oximeter device. Establish a relationship with them. Get your blood pressure and other baseline labs and numbers assessed. Get the appropriate cancer screenings for your age and for your risk factors. Know where you stand. And remember to eat a balanced diet, incorporate fresh foods, avoid those sugary drinks and processed foods, get some regular physical activity. And if you're not feeling well, though, please do get your rest. And as always, manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Next week, we will be skipping due to the short week with Labor Day. And we'll see you again on Tuesday, September 10th. See you then.